This is, as is always the case with us, a meeting in public, and I would particularly welcome those members of the public who have joined us in the room this morning, and of course those who will watch this through webcast, either live today or after the recording of the meeting has gone up on the net. We are fundamentally committed to the reality that we take decisions in this board that affect the population, the health of the population of England, and it's right and appropriate that those decisions should be argued about and taken in public. But I would stress that alongside and in reinforcing what we do in public is an array of activity that occurs throughout the year and in between board meetings, in which the non-executives on the board work closely with the executives on the board to try to ensure that we have overall a very clear idea of the strategy that underlies the decisions that we'll be taking. So when we meet as a board like this, we have also been involved in two other ways in our meetings. The first is by having what we call on each of these occasions a development session, and that is all of the board members sitting around a table, actually literally sleeves rolled up, and arguing about key important issues that are going to come through to us eventually as strategy issues for the board in public to debate about, but which have to be worked up over time with board members. So just to give a sense of what we've been talking about, yesterday we spent some time considering alternative models of care, alternative relationships between primary and secondary care. We heard from two innovators, including Nick Harding from here in Birmingham, chairman of West Birmingham and Sandwell CCG, and Paul Mayers from Yeovil, to try to understand how two different organisations were redesigning care that they could provide so as to provide a seamless care pathway for patients. And then we turned, again, in early stage strategic thinking to understand what we would need to do as a national organisation around funding models and incentive models, not to impose a top-down remodelling of care, but to facilitate local decisions and to ensure that funding followed local choice. The second way in which we meet around these meetings is to have private board meetings, and we are quite insistent that business comes to what we call the Part 2 meeting, the private meeting of the board, only when there are very good reasons for meeting in private rather than in public. And for the most part, those are reasons which relate to commercial confidentiality or some form of parliamentary privilege. So to give two examples of the business that is occupying our private board agenda in this course of meetings. One is our discussions about primary care support services. We took these at our last meeting in public, and we also had a private meeting discussion then. We are continuing those meetings and those discussions in private because there are some quite complex legal issues that we're still struggling with, but in the context of a highly sensitive commercial confidentiality discussion about the future allocation of responsibilities for PCSS. The second matter that we will take in Part 2 relates to the board's consideration of our first formal annual report and statement of accounts. We'll be considering that later today. It will then go to our audit committee next week for sign-off, with our hope that we're then going to be in a position to lay the report before Parliament before the recess. The reason we're not able to take it today in public session is because of parliamentary privilege, but I would like, if I may, just to bend that rule slightly by saying what an exceptional job has been done by our finance team, by our audit committee, and by the clinical commissioning groups across the country. This is an immensely complex process of consolidating the accounts of 211 CCGs with our own, and being able to do that swiftly, efficiently, accurately, and with the capacity to table the annual report and accounts to Parliament before it rises for the recess. What I would like to do now then is to open the board meeting and to first of all record the appointment by the Secretary of State of 3 new non-executive directors to the board. These have been appointed after a highly competitive process, and I must say I am delighted with the outcome. First is Noel Gordon, who joins us today and has been participating in our development session yesterday and in our meetings today. And Noel brings an extraordinary expertise in organizational design, digitization, and the ability to use new technologies to transform the way in which the NHS will, for the future, I hope, be able to provide improved quality of care for patients. Secondly, Sir John Byrne. Sir John is a holder of an NHS endowed chair at the University of Newcastle in clinical genetics. He's one of the nation's, if not the world's, leaders in genetics. But alongside that is himself a distinguished clinical entrepreneur with spin-out companies and new devices, including a new device for genetic testing, which will be a portable handheld device which can allow clinicians much more accurately to target drugs to particular genetic profiles. Unfortunately, he's not able to be with us today because all 3 of the new directors took up responsibility only on Tuesday, the 1st of July, and he has other business, but he was able to join us last night for dinner. The third non-executive director, who again is unfortunately not able to join us today, is David Roberts. David has a distinguished career principally in the banking industry. Until recently was the deputy chair of the Lloyds Banking Group plc, which he has vacated upon being pre-announced as the new chairman of Nationwide Building Society. As with Noel, an extraordinary understanding of how new technologies can be deployed so as to improve the quality of service to customers and, in our context, to patients. So we welcome our 3 new colleagues to the board, and in conjunction with that, I would like to propose to the board the following internal appointments, which is the appointment of Noel Gordon and David Roberts to the Audit Committee, the appointment of Noel Gordon to the Finance and Investment Committee, and the appointment of Sir John Byrne to the Clinical Risk and Assurance Committee. May I assume that those appointments are agreed? Yep. Good. Thank you very much. We have then formally apologies for absence, of course, from the 2 that I've mentioned, from David Roberts and John Byrne, also from Karen Wheeler. I would like to, first of all, invite members of the board to declare any agenda items where there are potential conflicts of interest. And I start with one of my own. On item 9, we will be talking about genomics, including our relationship with the wholly government-owned company Genomics England Limited, and I am a board member of Genomics England Limited. Are there other interests which my colleagues would wish to declare?
Only that only points on the arrival of learning disability services in relation to the Winterbourne review item, so that it's known.
Okay, you captured that? Thank you. Are there no other declarations of interest? Right. Thank you very much. I would also, before we move into the substantive business, wish just to report to the board our pleasure at the awards in the Queen's Birthdays Honours List of knighthoods to Sir David Fish of UCL Partners, who is one of the leaders of one of our great academic health science centres, stroke networks, to Mike Deegan of Manchester, to Robert Francis, who of course conducted the Mid Staffordshire inquiry, and also honours to Amanda Doyle of Blackpool CCG and Steve Curl from Bassetlaw CCG. So I think we all recognise the contribution that all of them have made to the National Health Service. Right, may I then turn to the substantive business? We have the minutes of the previous meeting on the 15th of May. I've had no comments on the minutes, so I'm going to assume, unless contradicted, that they are acceptable to the board as an accurate record. Nor have I been notified of any matters arising, so I assume likewise. There is an action list in Annex B, which details the status of each action. I don't propose to go through that now, but to ask the members of the board to note it. and then to turn, if I may, to the Chief Executive's report. Chief Executive.
Thanks, Malcolm. So I'm just going to draw out 4 elements of my report, some of which will be dealt with in greater detail in the items that will follow. The first of which is current performance of the National Health Service through the services that we and the CCGs are commissioning. And the headline measures are, of course, of great importance to patients and to the people that we serve. We know that the people of England legitimately expect quick access to high-quality emergency services and fast access to planned surgery and other diagnostic care when that's required. And so one of the things that the NHS as a whole and we as the commissioning drivers and stewards have is a responsibility to ensure that that performance is sustained. When you look then at the performance for A&E and for emergency admissions, there clearly are substantial pressures across the National Health Service. We know that the A&E 4-hour standard was met last week, but is in some institutions under pressure, partly as a result of increasing numbers of people going to A&E for their care. So there were, for example, 459,000 people across the country who went to A&E last week, compared to 437,000 the same time a year ago. But when you look at what's happening at individual hospital level, you see that actually the link between how quickly hospital A&E departments are able to treat patients and the level of increase in the number of attendances is a pretty weak link. So there is actually a lot of work underway now in a number of hospitals that are experiencing pressures to ensure that they are able to, through their own management action as well as work with the CCGs, ensure that these standards are being met. In the case of emergency admissions, there are signs that emergency admissions are increasing at a faster rate than had been the case in previous years. But again, it's worth noting that about half of patients who are admitted to hospital as an emergency only stay somewhere between less than 1 day or 1 day in hospital. So understanding what it is that is changing in the support available in community health services, general practice, the social care services, such that this change is occurring, is something that is now underway. So there are 4 actions that follow, I think, from these A&E and emergency pressures. The first of which is that we have allocated the £400 million of support for the urgent and emergency care system much earlier than we did last year, and that's been allocated on a geographical fair shares basis. And we are clear that that money can be spent by the local groups who are getting together, the hospitals, the primary care social services, either in hospitals where that makes sense, or it can be spent in community health services, mental health services, social care services. But the fact is we need robust plans to demonstrate how that extra 400 million is going to make a difference. And more broadly, as we think about the commissioning system for next year, we are intending to look at a more fundamental redesign of the way funds flow for urgent and emergency care, so that, for example, ambulance trusts are not just being funded for transport, but also to treat people on the spot where that makes sense, to better connect the funding flows for outpatient care, for A&E care, for out-of-hours care, for ambulance care, for all of the different elements that, as Bruce's review of urgent and emergency care made clear, need to connect in a much more joined-up way than has been the case until now. So clearly pressures in the A&E and emergency admissions area, but significant work now going on locally with the £400 million to identify how the best new services can be put in place to deal with that, and much greater line of sight to what are the root causes of some of this, given the great geographical variability we see across the country. In terms of waiting times for planned surgery, the performance on average continues to be strong. The median waiting time for a person having routine surgery last month was 8.6 weeks, so it's a very short period of time. But obviously, we know that pressures, again, have been building as there has been a higher referral rate, and as the result, we have been able to allocate £250 million of additional funding over and above what was in the CCG allocations to ensure that extra operations are being funded over the course of the next several months. Paradoxically, what that will mean is that as some of the patients who've been waiting longer are now treated as part of the backlog catch-up programme over the summer and early autumn, the measured waiting time of the people who are getting an operation will actually appear to get worse over the next several months, even though actually what NHS hospitals are doing is treating more people and dealing with the backlog. So we just need to all understand that that's what the measured performance will show. That in itself is perfectly consistent with the actions that NHS hospitals and other providers are going to be taking to ensure that we get waiting times back on track by the autumn. So those are some of the immediate headlines in NHS performance terms. We will have a chance to get into that in more detail in the NHS performance report, which follows on the agenda. The second of my four things that I would just draw your attention to is work which continues for 2015-16, particularly in the context of the Better Care Fund, which, as you know, is the incremental £1.9 billion which is going to be deployed jointly through local health and wellbeing boards for health and social services to produce more joined up community services, and very constructive conversations underway across government and with local government about ensuring that we have real line of sight and clarity about what that funding will deliver, and that it will in part create value and reduce pressure in the National Health Service. And further announcements will be made about that shortly as to how that's going to be progressed. Barbara is going to serve as the SRO for this programme, and I've asked Andrew Ridley, who leads our commissioning support unit in North and East London, to act as the project director for us there, working for Barbara. Thirdly, just to say that we continue to make progress in terms of NHS England itself and our organisational redesign. We are now clear about the changes that we have been making, the small number of changes to our national directorate structure, and are in the process of discussing with our regions and our area teams what the best way of ensuring smoother working practices and processes there. And we are also in conversation with a range of national partners about some of the functions that NHS England initially was asked to take on, but which more appropriately now it is felt belong elsewhere in the health system. I am pleased to announce 3 new appointments today that I think will add great value to the organisation. The first is that I've appointed Dr. Maheben Marathapu to my office, the Chief Executive's office, as the first of a new breed of clinical and managerial fellows from the front line of the NHS, getting experience for the strategic and operational decision-making at a senior level. Maheben is currently at Imperial College and is also the Chief Innovation Officer for TEDMed London. We are appointing Ian Dodge as our new Director of Commissioning Strategy, as the successor to Bill McCarthy. Ian is currently Policy Director at the Department of Health. And I have asked Joe Lenihan, who is currently Director of Strategy and Workforce at Health Education England, to join us on secondment for the next 4 months or so, while continuing to serve as Director at HEE, to be the Project Director for our 5-year Forward View programme, working in partnership with many of the other national NHS arm's length bodies as well. So I think those 3 appointments will make a good difference. Very pleased about those. And then the fourth and final thing I was going to say was that at the last meeting we talked about the continuing weight that we attach as an organisation to transparency and openness. And so I'm very grateful for the work that Jane and Tim did in terms of the publication online of the nurse staffing levels that we saw across the NHS, the patient safety information, our participation with others in the Sign Up to Safety campaign, which is intended to save up to 6,000 lives as a result of ensuring the reliability of care across the NHS and halving the cost of mistakes when they occur. And also we gave a commitment at the last meeting that we would now routinely publish on a quarterly basis not only the material that we'd previously been publishing around expenses and hospitality, but also details of our external meetings by the national directors with non-public sector organisations, and we will be posting those on our website tomorrow. So I think, Malcolm, those would be the four things I would kick us off with, but I think we will get into a number of those in more detail as we work through the agenda.
Well, thank you very much, Simon, and indeed we will. Can I just invite any members of the board to raise any questions or queries now on those items which we will not be pursuing in greater detail later on? Yes, Myra.
Could I just express some sympathy, as it were? Obviously, Simon's talked about the performance of the NHS, which is absolutely our first concern, serving patients and the public, but the impact on our staff of a further reorganisation. It's a very new organisation. It's, heroic efforts have gone into ensuring it, and I think it's worth noting that it is, again, a destabilising fact for staff in the organisation to be going through another reorganisation, as it were. I mean, there is no alternative in a sense except to do it as well as possible, but I think that the board should be aware of the impact on staff.
Yes. So just, I agree with you completely. I mean, I think there are kind of two thoughts behind this. One is our own staff survey, the feedback from our external stakeholders all says that after a very strong first year of operation, nevertheless, there are things we can do to improve the way in which we work to really punch to our weight and become more than some of our parts in terms of our internal processes. So I think everybody is keen that we do that. Secondly, however, there is an external imperative that perhaps you're referring to, Moira, which is that together with other parts of the NHS, we are obviously facing a substantial reduction in running costs from next April, and therefore we need to also take action to take administrative cost out of the National Health Service. And rather than doing those as two separate exercises, obviously it makes sense to join them up as one. But our aim is to have this nailed by the early autumn in terms of the direction that we're headed, so everybody can plan accordingly.
Okay, well, thanks. We note, Simon, your report. Thank you very much.